Good afternoon, guys. I'll be right with you. I've got to set up the show and then we'll get going, okay? Just 1 second. Okay, today's topic is seniors and drug overdoses. I'm going to go through that for you now. The headline: Drug overdoses spike 11% in older adults, and ageism keeps many from getting help. Reflects a troubling and under-recognized public health crisis, as detailed in the article by Jessica Hall. Here's a breakdown of the key insights from the surrounding page content. Overdose spike among seniors. Older adults 65 and older saw an 11.4% increase in drug overdose rates from 2022 to 2023, the highest of any age group. In 2022 alone, 52,000 Medicare beneficiaries experienced an opioid overdose. Just 1 second, gotta change paper. Six 6.4 million Medicare recipients had a substance use disorder, with 1.9 million specifically struggling with opioid use disorder. Why older adults are vulnerable. Chronic pain is common among seniors, e.g., 80% have arthritis, leading to widespread opioid use. Slow metabolism. In older adults means opioids, pain medication linger longer, increasing risk of interactions and side effects. Polypharmacy and lack of coordinated care contribute to unmanaged medication risk. Providers often overlook substance abuse in seniors, assuming symptoms like forgetfulness or instability are due to aging. Addiction screenings are rare for older adults, partly due to the stereotype that seniors don't misuse drugs. Some doctors even believe it's too late to intervene, which leads to neglect in treatment and prevention. Systematic gaps in care. Fewer than 40% of Medicare beneficiaries with opioid use disorder receive proper care under standard quality measures. Medicare Advantage and traditional Medicare underperform compared to Medicaid. In addition, in addiction treatment, benchmarkers, prescription reviews, and preventative conversations are often skipped during routine visits. Cultural and generational factors. Today's older adults came of age during the drug, sex, and rock and roll era. They're not inherently advised to substance use. Many seniors trust their doctors impeccably, assuming prescribed medications are safe without question. The piece underscores how ageist assumptions and systematic neglect are fueling a silent epidemic. It's not just about over prescription. It's about the future, the failure to recognize, screen, and treat addiction in older populations with the same urgency and compassion afforded to younger ones. Would you like to explore how these insights could inform culturally responsive interventions or myth busting resources for aging communities? These statistics offer a compelling foundation for targeted, equality driven policy reforms in aging and addiction care. Here's how they can be translated into actionable policy shifts. Policy implications from the data. expand screenings and prevention protocols. Problems. Problem. Fewer than 40% of older adults with opioid use disorder receive quality care. Policy response. Mandate routine substance use screenings for Medicare beneficiaries, especially during transitions of care, e.g., hospital discharge, new prescriptions. Improve Medicare addiction treatment standards. Problem. Only 11% of Medicare patients initiate treatment, and just 38% receive follow-up within 30 days. Policy response. Align Medicare with Medicaid's more effective addiction care. Benchmarkers and incentivize providers to meet follow-up and treatment into in intuition. Targets. Combat ageism in clinical practice. Problem. Providers often misattribute addiction symptoms to aging, leading to underdiagnosis. Policy response. Fund training programs to dismandate ageist assumptions in healthcare, require continuing education and geriatric addiction and treatment and trauma informed care. And enhance prescription oversight. Problem. Seniors are often prescribed opioids for chronic pain without adequate review. Policy response. Implement mandatory medication recalculation and deprescribed protocols for older adults on multiple medications. Support community-based health reduction. Problem. Cultural stigma and generational norms hinder help seeking. Policy response. Invest in culturally tailored outreach, peer support models, and caregiver education especially in rural areas and underserved communities. Integrate behavioral health into aging services. Substance use disorder or soloed from aging and mental health services. Policy response. Embed behavioral health uh, specialists into or in senior centers, home care programs, and long-term care facilities. If you're interested, we could co-design a policy brief or toolkit that maps these recommendations to specific stockholders like CMS, state health departments, or aging advocacy coordination co- uh, coalitions. Want to build that out together? Absolutely. While the article itself highlights gaps in care, we can we can draw on broader evidence and real-world models that have successfully addressed similar challenges in aging and addiction. Here are several policy examples, each rooted in the kinds of stats that stats you flagged. Examples of successful policies inspired by the data. Medicaid's integrated behavioral health models. Why it matters. Medicaid Medicaid outperforms Medicare on all three addiction care quality measures. Success story. States like Vermont and Arizona have implemented integrated care models that co locate behavioral health with primary care, improving treatment initiation and follow up. Policy takeaway. Medicare could adapt similar integration strategies, especially for older adults with complex needs. California's medication therapy management MTM for seniors. Why it matters. Poly- poly- Polypharmacy and um, unmanaged prescriptions are are a are major overdose risks. Success story. California's MTM programs involve pharmacists in reviewing seniors' medication reducing reducing adverse drug events and unnecessary opo- opioid use. Policy takeaway: expand MTM under Medicare Part D and incentivize deprescribing protocols. Massachusetts: screening, brief interventions, and a referral to treatment is SBIRT. Okay, we'll discuss that in a second here. Why it matters. Addiction screenings are rare among older adults. Success story: SBIRT has been successfully implemented in elder care settings, identifying substance misuse early and correcting connecting patients to care. Policy takeaway: make SBIRT a reimbursable service under Medicare and embed an annual wellness visit. Washington State's chronic pain self-management program. Why it matters. 80% of older adults have arthritis, and often leading to opioid prescriptions. Success story: these programs teach non-pharmacological pain management. E.g., exercise, mindfulness, reducing reliance on medications, reliance on opioids. Policy takeaway: funding community-based initiatives, alternatives to pain management through aging services networks. New York's older adult behavioral health collaborative. Why it matters. Isolation and ageism obscure addiction symptoms. Success story: this initiative trains providers to recognize behavioral health issues in seniors and builds cross-sector partnerships. Replicate collaborative models that bridge aging, mental health, and substance use disorders. If you'd like, we could co-develop a policy matrix that maps these models into federal, state, and local levels, especially for rural aging populations or culturally specific interventions. Want to sketch that out together? Absolutely. Let's unpack the real world uh, impact of the successful policies we discussed, especially in light of the troubling stats around older adult overdoses and systematic ageism in care. Impact of successful policies in older adult substance use. Integrated behavioral health models. Medicaid. Impact. States like Vermont and Arizona saw increased treatment engagement and reduced emergency visits for opioid use disorder. Why it works. Co-locating mental health and addiction services with primary care reduces stigma and improves access, especially for older adults who may not seek out standalone addiction clinics. Medication therapy management, California. Impact. MTM programs lead to fewer adverse drug events and better pain management and alternatives. Why it works. Pharmacist-led reviews catch risky drug interactions and help depression, opioids, help deprescribe opioids safely, which is critical for seniors with slower metabolisms and policy pharmacy risk. SBIRT in elder care settings, Massachusetts. Early identification of substance misuse, increased referrals to treatment, and reduced long-term dependency. Why it matters. Embedding screening into routine visits normalizes the conversations and counters ageism assumptions that older adults don't misuse substances. Chronic pain and self-management programs. Washington State impact. Uh, Participants reported reduced reliance on opioids and improved quality of life. Why it matters. Teaching non pharmacological pain strategies empowers older adults and shifts the norm away from automatic prescribing. Older Adults Behavioral Health Collaborative, New York. Impact. Improved provider awareness and cross sector coordination led to better better detection and treatment of addiction in seniors. Okay, guys, so that is A for you. I'll be back on with B shortly. Give me a little bit for B, please, and I'll be back on with that for you.